Hello and good evening, dear students. I am Dr. Ruchi Raj. I am a prosthodontic mentor at DBMCI MDS, and I welcome you all to the live classes of the subject of prostho. For all those who are joining me for the first time here and meeting on this platform, hi, my name is Dr. Ruchi Raj. I have completed my MDS in prosthodontics from AIMS New Delhi, and I'm a mentor at DBMCI MDS. So let me just open up the YouTube link and I welcome all of you for today's session. So very good evening, all of our students that have joined in. Quite a few number of students have joined the session. And yes, very good evening to Ganesh, Alia, Nikhil, Namrata, Harshita, Nandini, Ruhani, Shweta, Tanya, Garima. So a lot of students have joined and I hope you're excited for our sessions. So before we begin with the sessions and the different topics that we are going to cover, I'll just give you a brief on the subject. So prosthodontics as a whole, is a very vast subject. We start learning it from first BDS onwards and we go on learning it till almost our final year. We appear for exams in final year, practice it through internship, and still there are sections of it that are actually not taught at graduate level that you again study at postgraduate level. It is a very diverse subject in total. Now, from exam point of view, we have categorized it into complete dentures, partial dentures, fixed partial dentures, then implants, occlusion, maxillofacial in general. Now, how we are going to take up these live classes is that all of the topics that I'm going to cover here primarily will be there for good concept building. And then obviously you will have topics in between that are meant just for memory purposes or something that you need to memorize as classifications or tables, which I'll mention at that point. But the main aim of this class is you build good, strong concepts about your subject from the different topics that we are discussing, right? So today we will begin with complete dentures. And the first and very important thing that I will discuss under complete dentures is the meaning of retention, stability, and support. Now, the students who have seen my recordings or maybe have attended some sessions before know that I do stress on this particular topic, which is retention, stability, and support, because this I consider is the dictionary of your prosto. These three terms is something that you should be crisp clear with. What retention means, what stability means, and what support means. Because in our upcoming classes, I'll use these terms very frequently. At that point, it should click very clearly in your mind that, okay, this is what it is supposed to mean. Maybe a lot of your problems will be sorted after understanding these words, right? So, I'll just have a look. We have a very good number watching us on YouTube. Also, there are about 184 students, and I'll keep an eye on the queries also. Let us have an interactive session. If you have queries, please post them. Now, I try to follow the pattern or the sequence of topics that are going to be there in your notes. And the images that I have kept in my recordings and notes are the same images in the live classes. So, what instructions I'll give you before we start discussing the topics is that focus on the lecture, focus on understanding the concept. The notes can be formed later on also, but the interactive understanding of concept may not happen again. So first focus on that. If something is left behind, you can always go back and see the video or recording and make your notes again. So first primarily focus on that. Secondly, almost I think everything that we are going to cover is there in your notes. So you can sit down with it and make your additional points within your notes and your booklet onto it, right? Third, all of the live class that I'm going to cover is primarily for discussing your concepts. So my focus will be on that. The recordings that we have done, what you call as the recorded class of the subject, the 30 hours of video, is a very wholesome video where we explain it like how we take theory classes. But here it is a live interactive session where I am trying to make you understand the concepts better, what kind of questions can come out of it, and probably solve your doubts along the way. What is just for memory purpose is something that I'll also inform you that look, this is something that you can revise 10 days or 15 days before your exam. So that is how the theme of our session will go for the next 1 week. I hope all of you, very good evening. Yes, Ruhani. So I hope I have solved your doubt. And about 199 students, that is a very good number. Let us begin with the terminology, retention, stability, and support. Now, Prosthodontic terms defines retention as that quality inherent in a dental prosthesis acting to resist the forces of dislodgement along the path of placement. This is called as retention. Now, this is something that I think all of you have probably memorized and then blurted it out in front of the examiner. Now, let us understand what retention is. Grossly, I would say something that prevents the maxillary denture from falling down and something that prevents the lifting of mandibular denture. This is called as retention. Now let us understand it in detail. So that quality inherent in the process is so very important is this in the processes. So that quality inherent in the processes, which means that retention is a property of the processes. Retention is a property of the processes acting to resist the forces of dislodgement along the path of placement. Or previously it used to be like that property inherent in the processes that will counteract the adhesiveness of food or anything that tries to dislodge the processes. Now, first thing we need to remember, it is a property of the processes. Now, who gives this property to the prosthesis? The clinician imparts it. How does the clinician impart this property to the prosthesis? Through the different steps of prosthesis construction that we do. So, for example, if you are making a complete denture, the different steps of denture construction, for example, making a primer impression, doing good border molding, engaging your undercuts, having a very good impression technique, all of these different steps will help you impart retention to the prosthesis. So this is how we impart retention as clinicians to the prosthesis. It is a property of the prosthesis. And what does it do? Anything that tries to make the maxillary denture fall down or anything that tries to lift up and dislodge the mandibular denture, anything that will prevent these forces and hold the dentures in position, that property is called retention. Now, this, I hope you have understood. This is retention. What does this mean now? Retentive areas, right? Anything that helps contribute to retention. So anything that helps you contribute to retention. So for example, undercut helps me contributing to retention, or adhesive helps you contribute to retention, or a good impression helps you to that. So all of these things are contributing factors to retention or factors that help with retention. Different areas of the mouth that help with retention, they are called as retentive areas because they contribute to the property of retention. So this is what retention means. I think you have understood it. If yes, just give me a quick thumbs up and we can proceed to the next property now. That will be stability. Just a quick thumbs up, everyone. If you understood it, just a quick thumbs up. Yes. So I think we are receiving some thumbs up. Yes. Excellent. Now, let us understand the second thing. In our oral cavity, lot of action is going on. Different kinds of forces are generated. Grossly, I classify it as functional forces, parafunctional forces. This is no textbook definition. Functional forces are what? Anything that is generated during functional activities. Speech, swallowing, chewing, all of these are functional activities, normal physiological activities. Now, what is parafunction? Cruxing, grinding, clenching, everything that generates it is called parafunction. All of these forces can be categorized into these. And all of these forces that are generated are usually vertical plus horizontal both. They have a vertical as well as horizontal component. None of the forces generated in the mouth are either a straightforward vertical or a straightforward horizontal component. They are generally a combination of both of them. Retention works along the vertical forces because it is generally in this direction. Anything that falls down or lifts up, so it negates these kind of vertical forces. But stability is something else. What is stability? That quality of maintaining a constant character or position in the presence of forces that threaten to disturb it. Confusing. Let us see the other definition now. The quality of a complete or removable partial denture to be firm, steady, or constant, to resist displacement by functional, horizontal, or rotational stresses. Still, uh, I would say confusing. Okay, let someone is saying my voice. Okay, my voice breaks when I move aside. Okay, I'll try to be stable at one point. Good thing you have mentioned it. I'll try to keep it in mind. Fine. Now, stability is what? Stability, the definition says, denture to be firm, steady, or constant to resist displacement by functional, horizontal, or rotational stresses. Now, what exactly stability means? Stability in Hindi is called sthirta, something that is stable, right? I've given this example before also. Let me give it again. If there is a chair and there are four legs of the chair, you cut off 1 inch from one of the leg, the chair starts to rock like this. What do we call it? This is an unstable chair because it is rocking or moving. Anything that prevents this rocking movement of the denture, this rocking movement, I would say this rocking movement of the denture, right? This movement, that is called as stability. So what happens in the oral cavity now? Supposedly, this are your denture and it will receive forces like these, right? It will receive forces like these. These are oblique or horizontal forces coming in this direction. Where do they come from? Tongue and cheeks. Tongue and cheeks are generally contributors of this. So when they receive forces like these, then the denture has a tendency to shift or move like this. Any property of the denture which prevents this rocking movement against your functional or horizontal stresses. Let us now read it again, right? What was the definition? That quality of complete or removable partial denture to be firm, steady, and constant. That means to be stable on its denture foundation area, to resist the displacement by functional, horizontal, or rotational stresses, or resistance to horizontal displacement of prosthesis. This property is called stability. So retention is something that prevents the denture from falling down. Stability is that which prevents this particular rocking movement. I hope this particular aspect is also clear, students. So give me a thumbs up if stability, retention, both are clear. In simpler terms, anything that prevents the denture from falling down from maxilla or lifting up from mandible is retention. Anything that prevents this rocking movement of denture is stability. Shruti, I just explained both of the terminologies. Okay, Amano, difference between functional, parafunctional is functional are your normal physiological activities. Parafunction is like clenching, grinding, bruxing that you do. That is called parafunctional activities, right? So stability and retention. Now, the biggest contributor to stability in Hindi, I'll say one thing, isko gaant बांध के रख लेना means something that you have to always keep it in mind. Biggest factor, or right, I would say the main contributor for stability is what? Any guesses, anyone? What is the biggest factor for stability? I'll wait 10 seconds if you are able to answer it. If you have seen any classes previously or you've seen any recording. Biggest factor for stability is anyone? Yes, excellent. So, a lot of you have answered. Biggest factor responsible for stability is occlusion. Now, why occlusion? I don't know. None of you actually asked me this question, why occlusion, but let me explain. For example, in a denture like this, if there is just one point which is creating a deflection, which is a high point or a premature contact, the denture will click at that particular point first. And when they click at this particular point first, there's a tendency to generate horizontal forces like this that can dislodge the denture from its foundation. That is how it loses its stability. So, stability, biggest factor is your occlusion and support. Rather simple concept, the foundation on which a dental prosthesis rests with respect to dental prosthesis, the resistance to forces directed towards basal seat area. This is the one that we follow. The resistance to forces directed towards the basal tissue or underlying structure. So let us take that example of the chair once more. The chair on which, for example, right now that I'm sitting, the four legs of the chair provide support. They take my body weight, transfer it to floor underneath. Similarly, the oral cavity structures on which the denture rests, these structures provide support to the denture. They absorb all of your occlusal forces, transfer it to the bone which is present underneath. So, support and stability, the support, stability, and retention, these are the three main terminologies that you have to understand. Support is the foundation area on which a dental prosthesis would rest with respect to dental prosthesis. The resistance to forces directed towards basal seat area or underlying structures is also called as support. So, support exactly is what? In the mouth, there are some structures. These are called as supporting structures. So, these structures, for example, in maxilla, we have our hard palate. In mandible, we have our buccal shelf area, right? The purpose of these structures is they absorb all of the occlusal forces and transfer it towards your underlying basal bone or the uh, bone of maxilla or mandible, right? So, supporting structures are these. So, anything that contributes to the property of support are called as supporting structures. So, we have retentive areas in the mouth, we have some factors that contribute to stability, and we have supporting structures. Remember, all of these properties are imparted to a prosthesis through different steps of denture construction by the clinician. Now, the meaning of all of these three terminologies remains the same throughout complete dentures, partial dentures, implants, FPD, wherever in prosthodontics. The meaning of all three of them remains the same. So when I say basal, your hard palate is responsible for giving support to denture, you should be able to figure out that this area of the mouth will be able to bear all of the forces that are directed towards it and transfer it to the underlying bone. Or when I say that there's an undercut which is present next to tuberosity, which is responsible for retention, you should understand what retentive areas mean. Or when I speak about an occlusal scheme and talk in terms of stability, you should be able to figure out that it is preventing the rocking movement. So this is how these three terminologies are. I hope you have understood them. And now let us start with anatomical landmarks. Right? So, students, are you able to follow all of what we have discussed till now? Retention, stability, support, all three terminologies. I hope you are able to follow them. I'll just quickly have a look at our chat and see if there are Any questions? Yes? Okay. Is the speed fine for all of you? Is the speed of the session fine for all of you? Fine. Yes. So now let us begin. Okay, so two students have actually requested to explain certain parts in Hindi. We prefer to conduct these sessions primarily in English only because there are a lot of students from down south who have specifically requested to keep the sessions in English. But we'll try to mix both of them up. And apart from that, okay, the voice is an issue. We'll try to position the mic in a different way tomorrow and we'll see how it goes. For today, I'll try to be in the center more so that you don't face these kind of issues. Usually, we've not faced issues with this setup, but let's see tomorrow if we can change and improve this. So, with the voice, just please try and adjust something, put in a headphone or something so it's much clearer to you. And I apologize for that. But for tomorrow, we'll try to adjust something. Okay. Tomorrow, or I'm saying the next class. Now, let us start with anatomical landmarks. Right? Now, so we begin first with maxillary anatomical landmarks. Now, landmarks is something that we study just to understand what are the normal structures in mouth so that we can differentiate what is abnormal. We can effectively utilize these different structures of the oral cavity and then proceed towards a better denture construction. So, study of these landmarks that we do. Let me just open up. Yes. So, study of the landmarks that we do, they are divided into three categories: support or stress bearing area, relieving areas, and then we have limiting structures. So we have three kinds: support, relief, and limiting. Broadly, if I tell you how we discuss the property of support or stress bearing areas, those structures of the mouth that can bear the occlusal load that is generated during the functional activities and transfer it to the underlying structure. These are your supportive or stress bearing structures. Now, in absolute contrast to it, those areas of the mouth that cannot absolutely take up any occlusal load and have to be relieved from it. If you put any occlusal load of them, usually they'll be traumatized. They are relief or relieving structures. And those that form the boundary of your denture, that form the outer limit of your denture, that means denture should not go beyond this limit, that are called as limiting structures. Now, this is something that you would have read in your first BDS also in your preclinical classes. Let us enlist them very quickly for maxilla. So for maxilla, the supporting structure is your hard palate. Now, somehow this has become a controversial question over the years, and I'll explain you why it has happened. Remember it very clearly. There is nothing given in vouchers very specifically as primary and secondary stress bearing area. In vouchers, it is written the area that contributes to support or stress bearing is hard palate. Now, there is some confusion because of different question banks where somewhere answer is given as alveolar ridge, as supportive area of maxilla, somewhere maybe rugae also has been given as the answer. In previous editions of voucher, 9th edition, 10th edition, The statement written there was alveolar ridge. That is why those MCQs that were asked in the 90s or maybe early 2000 or something may have that answer considering that voucher as a reference. But in the recent editions of voucher, if you go 11th edition and afterwards, it has been very clearly mentioned hard palate is the stress bearing area in maxilla. Of course, there are other areas also like your rugae, maxillary tuberosity, alveolar ridge that contribute to support. But your main stress bearing area of maxilla is hard palate. So this should not create any confusion down from here. Hard palate is the primary stress bearing area. Now, what are relieving structures in maxilla? So incisive papilla. Incisive papilla is a relieving structure. Mid-palatine raphe. Mid-palatine raphe. And then fovea palatini. Fovea palatini is also your relieving structure. And what are your limiting structures? All your frenums plus vestibule. So labial as well as buccal. Labial and buccal, frenum and vestibule. Posteriorly, you have your hamular notch and your posterior palatal seal area. These are in general your anatomical landmarks of maxilla. We will start discussing all of them in detail now. Let me have a look at our YouTube chat also so that we can just keep an eye onto it. Okay. So let me just quickly answer your questions and then we start with the landmarks. So Vishal is asking, ma'am, denture base help in support or basal seat provides support? Your denture base is responsible for support. That is that part of the denture that is responsible for involving in the property of support. But the area of the mouth that contributes to it is your basal seat area. Now, what is rocking movement? This anything like this. If the denture moves like this, it shifts like this. This is called as rocking movement. वो rocking chair होता है ना, like this. That is a rocking movement, right? Now, Subiksha is asking when there is less stability of denture, there will be rocking movements. Yes, absolutely. And Shruti is asking what is residual ridge. You and I, we have a set of teeth in our mouth. As soon as all of the teeth are removed, what is remaining in the mouth is called as residual alveolar ridge, the bone that remains in place of your teeth. That is called as your residual alveolar ridge, right? Now let us move towards your landmarks and start with labial frenum. Now see, in the initial 1 hour or so, it will be theoretical because we are discussing landmarks. Your conceptual learning starts at impression and jaw relation. So you'll have to bear with me till then. Initial part may look a little boring, but let us get through it because this gives you marks and MCQs. These are straightforward cash MCQs, right? So labial frenum, you can see it over here in the arrow that is pointed. Remember, frenum word means it is a fold of mucous membrane where the mucous membrane folds. So labial frenum present in the midline of maxilla, present between the lip and underside of the lip and the labial surface of maxillary ridge. Now, I will write down key points on the screen here. Rest things I'll explain it to you. Try and focus on the explanation. So labial frenum, a fold of mucous membrane is present on the under surface of your lip or the inside of your lip and it attaches onto the labial surface over here. As you can see on the ridge, this is the labial surface of the ridge. So it is between your lip and the labial surface of the ridge. It is present in the midline. It is single or one in number. And it is generally a single eye-shaped vertical fold. And the most important thing that you have to remember is it has no muscle attachment. Now, let us understand one simple concept over here. Any structure in the mouth that has muscle attachment and any structure in the mouth that does not have muscle attachment, what implications it has in the stage of denture construction. Anything that has muscle attachment will move when the muscle moves. When does the muscle move? When some functional activities happen, like smiling, smirking, laughing, giggling, opening the mouth wide, yawning. These are all different functional movements which involve muscles. So any structure of the mouth, like for example, labial frenum or buccal frenum, which have muscular attachments, for example, those muscles, when they move, the frenum also moves. Now, what implication it has for a prosthodontist making a denture? You have to accommodate that shape and space. Mark my words and understand. You have to accommodate that shape and space for that movement of the structure in the denture border. You have to accommodate the shape plus space, both, for that particular structure while molding your denture border. And if you fail to do so, as soon as the structure, the muscle moves, the structure moves, what will happen? Denture will lose retention. Now I won't say denture will fall. I'll use the word denture will lose retention, or it can contribute to loss of stability also, but primarily denture loses retention. So this is something you need to understand. Now this is applicable to all of the structures that I'm explaining. So when I say no muscle attachment means you need to just give a zoom in onto it and erase, and I'll show how a denture border will look like for this particular labial frenum. Just this much. This is called as eye-shaped relief, or should I say just a eye-shape adjustment. Why? Frenum is not going to move because there are no muscle attachments. So you will just give an eye-shape relief. Now, one more thing when we proceed for the class and applicable to all of the other topics also. Prostho has tons of textbooks and years of study. On Frenum also we can write 25 pages if we want to. Is all of that relevant and necessary? No. So what we teach here is something that is relevant and necessary. Unnecessary things that have not been asked in past 20 years or 15 years, we will not include because we don't want to burden your head with information. Only crisp information which is necessary for exam, that will be included. So this is what is necessary for frenum. It is right there onto your screen. Main important thing which you have to remember is labial frenum has no muscle attachments. Now, let us move on to the next one, which is your buccal frenum, also labeled over here. This is my buccal frenum. Buccal frenum is labeled over here. Right? Now, again, it is a fold of mucous membrane. Buccal frenum can be single or it can be multiple, which means you can see 2 or 3 folds also sometimes. For example, you can see one fold here. You can even see a slight one fold over here also. So, buccal frenum can be single or it can be multiple also. Now, this buccal frenum has muscle attachments, right? So, let me draw it. If this is my triangular shaped buccal frenum and this is the mouth, or I should say the front part, and this is the palatal part or the back end of the mouth, then you will have orbicularis oris that pulls the frenum forwards. You have buccinator that pulls the frenum backwards, and you have levator anguli oris or caninus that will try to elevate the frenum upwards, right? So I've drawn and kept it actually. I've kept your notes also alongside me. So I have an idea what you don't need to write exactly. So this is something I think I've drawn in your notes also. So orbicularis oris present over here will pull the frenum anteriorly. Buccinator will pull the frenum posteriorly. Caninus will lift the frenum upwards. What implication it has for a prosthodontist making a denture? Now, when I see a buccal frenum like this, I need to give a wider relief for it. So instead of making just an I-shaped relief, I give what is called as a wide crescentric relief, a wider crescentric area that gives some space for the frenum to move. This is all something that is adjusted while border molding. So this is your buccal frenum. Let me have a look at our group also. Sorry, at our track. So just need to keep an eye onto it. Just a second. Okay. Okay, so shape and space portion for labial frenum. See, labial frenum has no muscular attachments, and since it has no muscular attachment, a simple I-shaped relief is sufficient for your labial frenum. I hope that part is clear. In contrast, buccal frenum has muscle attachments. That is why this buccal frenum would be given a wider relief like this, in contrast to the I-shaped relief of your labial frenum, right? Now, apart from that, the triangular structure, Chirag, that I've drawn is just a schematic representation. Exactly, it won't be a triangle, but you can see how buccal frenums are formed like this. See, this is a portion. So this is just a schematic representation like this. Right? For people who are saying the video is stuck, I think you can exit the link and join it once back. Maybe an internet issue for you, right? So buccal frenum, labial frenum is done. Now let us proceed to our sulcuses over here. Vestibule or sulcus. Fine. So let us proceed to vestibules or sulcus. Now students, in the image over here, I have labeled labial and buccal vestibules. The labial vestibule is present between the two buccal frenums. It is divided into right and left by the labial frenum. Buccal vestibule is something that is behind the buccal frenum till the hamular notch region. So labial frenum and buccal frenum and the spaces surrounding them are your vestibules. These vestibules are influenced by certain muscles. And when we do border molding and at the stage of impression, we try to mold them so that we have a well adapted border. That is the role of these vestibules. As a prosthodontist, what implication we have is we need to record the correct depth and the correct width of these kind of vestibules. Now, let us come to the more important part, and which is asked as MCQ also in exam. Now, this particular portion Let me have a look at the chat also. Now, the distobuccal part of the buccal vestibule. That means the part. Now, I'll ask you to do one thing. Take a clean index finger, right? Take your index finger and try to feel the area that of the sulcus that is alongside your first and second molar, right? Clean index finger, insert it into your mouth and put it in the region of your sulcus that is opposing first and second molar. This is the distobuccal part of your buccal sulcus. Now, what I'm talking about it here, listen very carefully. And we have a very good MCQ coming out from this particular region also. When we open our mouth and the mandible moves like this, the coronoid process comes anteriorly. Coronoid process of mandible. You all can try it right now. Put your index finger into the vestibule. Gently open your mouth. You will feel that width of the sulcus is reducing because the coronoid process comes anteriorly. So the implication here is that when the patient opens mouth, the width of the distobuccal part of your buccal sulcus or buccal vestibule reduces. So if you have not done this opening and closing movement of mandible during border molding, whenever the patient will open mouth or open wide mouth opening, then the denture will fall down because the distobuccal parts border molding will not have occurred properly. I'll repeat once more. This distobuccal part of buccal vestibule reduces in width. It reduces in width when mouth opening occurs. Right? Why it happens? Because the coronoid process comes over here. Coronoid process comes anteriorly. That is why this is happening. Now, if border molding has not been done adequately, that means when you're border molding the distobuccal part of your sulcus, you have to ask your patient to open the mouth wide, take the mandible in side to side movement. If this border molding has not been done adequately, the question that comes in exam is a denture patient complains of denture falling down when he opens the mouth wide. What is the reason for it? Reason for it is too thick denture border in the distobuccal part of the denture, or you can say your denture border interfering with the coronoid process. All of these are reasons for it, right? I hope this is something that you have understood. Now, where does the confusion occur? A similar question comes in exam where they say as soon as the patient is smiling, denture falls down. Now, when you smile, the buccal frenum here gets involved. So, this is the problem with buccal frenum. This problem is not of your of your coronoid process or your distobuccal region. Smiling and denture falling down, you need to relieve your buccal frenum. Wider opening and denture falling down, you need to reduce the thickness in the distobuccal part of your denture. This is a very important MCQ, comes in the exam. So just remember it. I hope this particular thing is clear. All of you, I'm keeping an eye onto the chat, but practically every second I cannot actually look at the screen because then my focus would be probably only on the chat. So let me have a look at our chat also. Meanwhile, you can even post up your queries or whatever suggestions you have. Fine. I think most of you are saying yes. So we have covered this, this frenum also, this, all of these. Now we are coming to the posterior limiting structure, which is hamular notch and then post palatal seal area. So let us understand this. This structure is maxillary tuberosity. This structure is tuberosity. As soon as you go behind the tuberosity, you have a C-shaped depression. That depression is called as hamular notch. Behind this hamular notch, you have something which is called as hamular process. So if this is your ridge and this is your tuberosity, behind the tuberosity you have a depression here which is your hamular notch. Behind the notch we have the hamular process, right? Now, how do I identify this hamular notch? You have to take an instrument which is called as a T-burnisher. So with the help of that T-burnisher, you can palpate the hamular notches. This forms the posterior most limit of the denture. Remember, hamular notch, the depression which is present posterior to maxillary tuberosity, forms the posterior most limit of denture. If you go beyond this and settle your denture onto hamular process, it is a process, it is a projection. On a projection, if you place your denture border, the patient will complain of a sharp pain. So again, a case-based question can come in exam as patient complains of a sharp pain in the posterior part of the mouth, and patient complains of this pain even while biting or closing the mouth. This is very strictly and clearly an indication that your denture may be overextended posteriorly and sitting onto hamular process. You have to reduce that area and it should be sitting into the hamular notch region. So that is one part of your posterior border. Second part is this. This is called as post-palatal seal area. This region is called as pterygomaxillary seal region in the hamular notch region, and between them is called as post-palatal seal area. Now, what my arrows are pointing is fovea palatini. Fovea palatini is an anatomical reference point at the posterior border. A very controversial question surrounding fovea palatini is regarding its location. My answer over here is very clear. Its position is not fixed. Its position varies. But what exactly is fovea palatini? It is coalescence of minor salivary gland ducts that is present in the posterior part of the mouth. It may serve as a reference for your posterior border, but since its position is not fixed, we will rely on to other landmarks rather than fovea palatini alone. Now, let us understand the posterior border of maxilla. So, like I have drawn, these are hamular notches, and then you have a cupid bow shape PPS in between. So this is your pterygomaxillary seal, and this is your post-palatal seal area. For hamular notches, I already explained you. For post-palatal seal area, there are two lines. This is called as anterior vibrating line. This is called as posterior vibrating line. Now, one more concept we need to understand is both of the vibrating lines are imaginary structures. That means these are imaginary lines that we draw in the mouth. As you can see over here, these are the lines that are present on the impression also. So why do we draw it in the mouth? For better understanding and recording purposes and to have a fair knowledge of where to place your impression material posteriorly and how to dampen that area. So what exactly vibrating lines are? Now, as the name suggests, they suggest some vibration. So what exactly vibration is it suggesting? Hard palate is a fixed, immovable structure. Soft palate is a movable structure. The junction between hard and soft palate, where there is no movement of hard palate and slight movement of the soft palate, that junction is denoted by anterior vibrating line. And there are areas of soft palate which will have very limited movement and which will have very grossly marked movement. The junction between both of them is denoted by posterior vibrating line. Area between anterior and posterior vibrating line is an area of very good resilient tissue over which you can do some sort of compression to create a border seal. That means you can create some pressure over it or you can push it slightly down below and it will not have any problem. That good resilient area is your posterior palatal seal area. Now, what exactly posterior palatal seal area is? Posterior palatal seal area is that area between these two vibrating lines that has good resilient tissue present over there. And why do we need this PPS area? First, to have good retention and stability in the denture. Second, there is a very good chance that acrylic will have some sort of shrinkage. So we need to compensate for this shrinkage in the denture. Third, we don't want any ingress of food from the posterior border into the denture. If that happens, then patient will have discomfort. Fourth, to reduce the gag reflex. To accommodate all of these things, we incorporate the PPS area into the denture. I'll discuss more onto PPS when we discuss impressions. Right? This is your posterior palatal seal area. Now, these are the limiting structures of your denture. And now let us discuss your supportive structures. This is just limiting structures. Let us now discuss the supporting structures. Now, supporting structures, remember very clearly, main is this hard palate. Boucher is not written anything about posterolateral slopes or anything. Main is this hard palate. It is good amount of cortical bone, has good trabecular bone inside. It is perpendicular to the direction of forces, and a lot of these reasons make it your supporting structure. Apart from that, this alveolar ridge is also an excellent contributor to support. So alveolar ridge can also give you support. Similarly, these maxillary tuberosities, they also have good amount of bone, can contribute to support. Now, one question comes in exam regarding undercuts surrounding maxillary tuberosity. What question comes in exam is that if there is an undercut present next to the tuberosity in this region, what will you do? I'll give you a very clear answer to it. If it is just a soft tissue undercut, you have to block and manage. If both of them are soft tissue undercut, right? And fairly such that can be conservatively managed. But if both are bony undercuts, you need surgical excision, because bony undercuts cannot be managed without surgery. Denture cannot insert only without causing trauma to the tissue. So bony undercuts, you have to surgically excise it. We don't completely remove it. We just adjust it till the point where the undercut can be utilized for denture construction. So surgery will be needed. So this is yet another MCQ for it. Soft tissue undercuts, block and manage conservatively unless it is too big that it cannot be managed conservatively. Bony undercuts, you will require surgery. This is in case of bilateral bony undercuts, I'm saying. What if it is a unilateral bony undercut and a other side there is nothing? A better option would be to go for the conservative answer, because nothing about size of the bony undercut is mentioned. But for example, it is stated that the bony undercut prevents entry of denture, or denture cannot be seated at all only, something like this. Then you have to go for surgical options. So check your question for things. What is written? Does it mention anything about size of undercut, size of the bony exostosis, or what problems it is causing? Is it hinting towards surgery? Then select that option. But if nothing about size and the other issues that it can cause is mentioned, go for a better conservative option that is applicable to all situations. So that is how you tackle these MCQs. Now, let us come to relieving structures. I'll quickly have a look at your chat, right? Yeah. Anjali has asked a very good question and something that I missed. How to identify anterior and posterior vibrating line? First, it comes out of experience. Second, when you ask your patient to say ah in short, vigorous bursts. Now, this is something that it's a very funny thing to say, and I say mazak nahi udana chahiye, but when a third final year intern student is doing all of this business in clinics and denture, it becomes a very funny scene for us, because A lot of you don't know how to actually say those words which are written in textbooks. And some patients are saying ah, some patients are saying something like that. If you don't say the correct word, it will not actually, you won't be able to see it. So the correct way is to say like this, short, vigorous burst. So you have to ask your patient to say like this in short, vigorous burst. You will see a strong junction between the hard palate and soft palate, where the movement of soft palate is starting. That is your anterior vibrating line, right? Posterior vibrating line comes out of experience, where you should be able to judge suddenly where soft palate is starting, very gross movement. You cannot place denture in that movable soft tissue. So you end your denture at that posterior vibrating line. Just very normally ask your patient to say ah, and you will be able to see posterior vibrating line. So that is ABL and PBL. Now, let us come to relieving structures. The first relieving structure here is incisive papilla. The first relieving structure is incisive papilla. Incisive papilla is relieved because it houses nasopalatine nerves and vessels. It houses nasopalatine nerves and vessels. That is why incisive papilla has to be relieved. If you cause compression over it, patient will complain of burning sensation, altered sensation, and paresthesia. So first relieving structure is nasopalatine nerves and vessels. Your incisive papilla. Second, mid-palatine raphe. Again, one MCQ we'll discuss over here. But please tell me, is the class going too slow for you? I'm intentionally keeping it slow in the first session. Once you and I develop a pace, I insert some concepts into your head, then we don't need to revise or repeat those concepts again. I'll say those words, you'll be able to follow them. So intentionally today's session will go a little slower, but we'll catch it up in the upcoming sessions also. So now tell me something. Is it too slow for you? You just put it in the chat and I'll have a look over it, right? Now, second is mid-palatine raphe. Now, your maxilla is actually not just one bone. These are two bones that are united in the center, which is called as the mid-palatal suture. And this center union that occurs is not flat like this. The union that occurs has the slight elevation. That suture elevation can be felt. A clean index finger, feel that suture in the mouth. Even you will also feel that suture. What happens is in patients where you have very resorbed ridges, I'm showing you a cross section. See, this is the cross section of a denture where these are your ridge height. Okay? Now, suppose this has all resorbed and a new situation has become like this, where ridges are completely flat. At that time, this suture in center becomes a point of fulcrum over which the denture can start rocking, and it can also fracture at this point in these kind of cases. So in mid-palatine raphe, first, because it is slight elevation. Secondly, there is absolutely no submucosa in this region. The mucosa is almost directly attached to the periosteum. We have to provide relief to this area. That is your mid-palatine raphe. Now, all fine? Okay, for majority, it is fine. Let us come to just a second. Yes. This is trying to show you the malar process or the zygomatic process. In some patients, you can feel it over there. The mucosa over it is very thin, so you need to provide relief. And lastly, we have our fovea. I again discussed it before. It's a coalescence of minor salivary gland. Now, question that comes here is that why do we give relief to fovea? It's a coalescence of minor salivary gland. So secretions are present over here. If the patient has thick ropey saliva, and pooling of saliva happens underneath your denture, the denture can dislodge. There's one more important part regarding the tissue of hard palate. Anterior part has adipose tissue. Posterior part has glandular tissue. There is an MCQ that I had explained, and I think it was converted into the form of a reel. It is still posted on Instagram only, where we form the question in a manner that a student comes with a final impression of an upper maxillary denture case, and there are some porosities or spots like this in the posterior part of the impression. What is the cause of it? The cause of it is this glandular tissue in the posterior part of maxilla. It releases secretions. So the correct way to make an impression is to wipe off this area just before seating your tray and then make an impression, because the glandular tissue secretions will cause these minor porosities into your impression. If you want, you can go check it out also. It is still posted, I guess, and you can have a look at the exact question. Apart from that, there are some other structures in the mouth, which is your rugae area here. Rugae area acts like a speed breaker. It prevents forward movement of denture. It helps with your phonetics also. So grossly, these are all of your anatomical landmarks of maxilla. This is a photo or an image that has been taken from vouchers. We have discussed your labial frenum. Starting from labial frenum, we have started frenum, buccal frenum. Then we went with labial vestibule, buccal vestibule on both of the sides. Hamular notches, posterior palatal seal area. We discussed our rugae, hard palate region also. All of our relieving structures present here. This is grossly all of your maxillary anatomical structures and several questions that come out of it. Now, this knowledge will help you with border molding also. There, we'll move on little faster than this, right? We have completed maxillary anatomical landmarks. Let us start with mandibular anatomical landmarks now. Let me have a quick look at our chat section also. Any queries, anything that you want to ask me, students? Just a quick look at your chat. Okay, so Ritik is asking a question. Is the classification for residual ridges important? Ritik, are you asking about the part, the different kinds of ridges, the kind of hard palate shapes with ridges? Are you asking about that? I think maybe that might be your doubt. Let me very briefly explain it to you. Okay. So we have different kinds of ridge shapes also. If you have a U-shaped vault like this is considered ideal because it provides you a flatter surface in the center with very good height and width of your ridges. So a U-shaped palatal wall with good high well-rounded ridges is considered your ideal. Now, if you have a V shape of palate, it is not providing you with any horizontal space here. So there is a tendency of denture rocking because you don't have any horizontal space like this for the denture to be firmly seated. And if you have flat resorbed cases like this, then there's absolutely no ridge height only. And when there is no ridge height, you will not have very good retention or stability. That is the basic three kinds of cross section of ridges that we see. So I hope that would be covered. Students, I think please keep some patience. There are different topics that you're mentioning here, which of course I'll cover in the upcoming parts, like details on soft palate and House classification. I'll cover while discussing impressions. I'll cover Atwood's classification while discussing residual ridge resorption. So all of that I'll do cover in the upcoming topics also. So with this, we conclude your maxillary anatomical landmark. So, do you want me to include soft palate in your uh, other part over here only? Okay, let me just quickly, because the students that are only for the YouTube session, they won't have access maybe to the later part. Let me cover the House classification. Fine. So, let us discuss the then we won't discuss it at the stage of impression. House classification for soft palate, right? So House classification for soft palate, it has three classes. Class 1, this is your hard palate, and this is, for example, your soft palate. Only about, say, 10-degree angle between both of them. Roughly about only 10-degree angle. If you see a very smooth transition, it will give you almost 5 millimeters of area over here for posterior palatal seal area damping. Damping means compression and is considered ideal for your denture cases. This is class 1 junction, ideal for your denture cases. Now, class 2. Hard palate is like this, soft palate at a much larger angle, almost 45-degree angle. So, this is 45-degree angle. So much sharper, I would say. I'm shying away from drawing, but a much sharper 45-degree angle. Now, this gives you lesser than 5 mm, almost say 2 mm, 3 mm, something like that. Lesser space. Not very ideal for retention, but not that bad also. And the third one is your danger most. Hard palate like this, soft palate drops downwards at 70-degree angle and it falls down like a curtain only. This will give you less than even 1 millimeters of area for posterior palatal seal. Now, all of these 10, 45 and 70-degree, how do you figure out? 70 is very clearly perceivable because it will look like a curtain only, the soft palate falling downwards. 10 is perceivable because you will be able to dampen that area. You will be able to compress that area, gain that wider, nice posterior palatal seal. Class 2 is something that falls between both of them that you will be able to perceive with experience also, right? So very strictly, it's difficult to differentiate between 1 and 2, but class 3 is something that will look like a curtain only that is falling from the behind the hard palate. So that is about your soft palate. Now, I think we have answered almost everything that is pertaining to your landmarks. Now start with mandibular anatomical landmarks. I'll give you a break in roughly 10 minutes at 6:50. So let me cover the introduction part of it and then we can start discussing the landmarks in detail and we can skip on to the sections then. So mandibular anatomical landmarks, same as maxillary. Again, the classification will be in three parts. Supporting, relief, and now limiting. Right? Now, we won't go into the details of explaining what frenum means, what vestibule means over here because now you know. Supporting structure, first is your buccal shelf area. Let me pull out the correct image for it. I want to explain buccal shelf area to you first. Okay, so let us start with buccal shelf area. It is the supporting structure of mandible. Now, students that can see here, probably I'll zoom in onto it. This is your buccal frenum here. This is the buccal frenum here. Fine. So starting point is buccal frenum. Ending point is starting of the retromolar pad area. Laterally, external oblique ridge. Medially, crest of the ridge. Now let me pull out a illustration for it over here. We'll draw it once more. Buccal frenum anteriorly is the starting point of buccal shelf area. Ending point where retromolar pad area will start. So area between retromolar pad and buccal frenum, laterally external oblique ridge. You will have to palpate it external oblique ridge in the sulcus. Medially crest of the ridge. So everything that falls in between is called as buccal shelf area. Buccal shelf area is an absolutely important structure in mandible. Why? Firstly, it receives all occlusal forces almost nearly perpendicular, so they can be dissipated very well. Second thing, which is very good, see, this is an alveolar ridge. This is where the sulcus would be. This would be sulcus. As and when the alveolar ridge will resorb and it will become flatter like this, the shelf area widens. Because as the ridge will resorb over here, the shelf area widens. So it increases with resorption. It gives a good foundation for your denture. It has good cortical bone. All of these reasons will make buccal shelf area your primary stress bearing area in mandible. Let me quickly just open up our chat also. So that is your buccal shelf area. Anjali is asking once more buccal shelf area. Okay. Yes, I think there is still some confusion regarding the smiling and the wide opening one. See, when you smile, your buccal frenum will move. So if you have not manipulated your buccal frenum very well, denture will fall down while smiling. But put your finger into your molar region in the sulcus and open your mouth and you will notice the reduction in width of your sulcus. That is because your coronoid process comes anteriorly at that point. So if you have not done this process during border molding and you have a very thick denture border over there, as soon as the patient opens the mouth wider, the denture will fall down. So very clearly you can just remember coronoid process, thick distobuccal border, wide opening, smiling, buccal freedom. These are modified into case-based questions. I hope that is clear. Students, can you give me a thumbs up if that portion is clear for all of you? Students, a quick thumbs up if this portion is clear. I'm keeping an eye onto the chat so we can have your queries answered for all the students that are joined on YouTube. Okay, so we are getting quite a lot of thumbs ups over here. Okay, we have quite a lot of thumbs up. Yes, yes. Okay. So, students, this is your buccal shelf area. Now, let us come to the frenums. I quickly want to cover this part also for our students that are joined in on YouTube so that they are able to at least take the anatomical landmarks portion and then we end this part of the session. So, Now, let us discuss labial frenum. You have to be a bit of a multitasker, keeping an eye on the tab, the screen, and the chat also. But that is what I think we are supposed to do. Very nice image of something that I want actually all of you to appreciate. Can you see this frenum here? This particular band. Let me erase it. I'll point it to you. This band. See how it is moving on one side like this. That is how movement of labial frenum and all of these frenums occur. Now, this is an I-shape relief. Fine. Now, in contrast to maxilla, your mandible has muscle attachments, not very gross muscle attachments, but has muscle attachment. Even mentalis is present over here. So, you give slightly wider relief to labial frenum in comparison to your buccal frenum. Now, notice how I told you that there can be two buccal frenum. Again, you can see two fibers over here, right? Wider crease-centric relief. Can you follow my pen and see? Wider crease-centric relief. Again, the muscles remain the same. The buccinator will pull here. Orbicularis oris will pull here. Depressor anguli oris. Maxillary one was levator anguli oris. Here it is depressor anguli oris. So depressor anguli oris will put it down. So we have labial frenum and we have buccal frenum. Right? Buccal frenum, wider crease-centric relief. Sulcuses remain the same only. Now this was our buccal shelf area. Now quickly again let's have a look at the chart. Just a second. Okay, so Bhavitra is asking a question: when alveolar ridge is resorbed, how does buccal shelf area widens? Okay, see, Bhavitra, understand over here. This region right now is buccal shelf area, the one that I've marked in blue. As soon as this portion resorbs and it settles down, this buccal shelf area, which is at an angle right now, can spread over a wider area like this. So instead of just this much area, it will become like this. That is how the area for it or the bone for it increases. Right now it is at an angle because you have good well-formed ridges. But when that ridge will resorb, you will have a wider buccal shelf area. That is how it goes, right? And Subiksha is asking a question. Again, Subiksha, better I'll tell you one thing. Please be little patient. I've just explained labial frenum, buccal frenum. I'm coming on to lingual frenum right now. So I'll explain it here, but don't please jump onto topics that have not yet been covered or that will be covered in the upcoming few minutes also. So just be patient. I think, see, pace of every student is different. And in the first class, what we do is we try and judge the pace of our students also, how much they are able to take up. I can see that we have a bunch of students that can grip and grasp very faster. But still, we have to be little slower in the initial part of the class, right? Apart from that, I don't see, I think, any queries over here. Now, lingual frenum, like Subiksha was asking, this is your lingual frenum present in the center of the mouth on the lingual side. It is an additional frenum in comparison to your maxilla. The only relationship we have is that you have to relieve it very well during border molding movements of which I'll teach you when we do border molding, and tongue tie, which is a shorter lingual frenum. If it is present, it can lead to loss of retention, so it has to be relieved. Now, let us come to vestibules. Labial vestibule again related to your mentalis muscle. Now, a question pertaining to buccal vestibule that comes, and let us solve that, right? Let me quickly find the correct, yes, image for it. So this particular region over here, the distal buccal part of the buccal vestibule forms what is called as masseteric notch in your impression, right? In the buccal side here, you will find a masseteric notch. So anatomy wise, if you see, you have your buccinator muscle here, and then you have your masseter muscle. So masseter, a muscle, when it does forceful contraction, it pushes the buccinator inside. When it pushes the buccinator inside, it creates an inward bulge, and that bulge will create a notch onto the impression over here. So it creates a notch-like formation. You can probably see this notch here, this notch which is forming. That is your masseteric notch which is forming. So the influence of strong forceful contraction of masseter on buccinator is called as masseteric notch, which is seen in the distrobuccal part of your mandible denture or denture impression. Now, we have just a second. I want to fetch one image. Yes, this image over here. So in this portion, you will have masseteric notch forming. Now, the distal part, anatomy related to distal part is very important and it comes quite frequently in exam. Just a second. Let me draw it over here. So in the distal part, we have what we call as retromolar pad area, and the surrounding anatomy of retromolar pad area is that it has tendon of temporalis, it has buccinator, masseter, and then it has superior constrictor and your pterigo mandibular raphe. So again, the posterior part of mandibular denture is also very important. You have retromolar pad area. If you go laterally, you have buccinator and masseter. If you go medially, you have superior constrictor, pterygomandibular raphe. Posteriorly, when you go, you have tendon of temporalis. So here in the posterior most part, you will have tendon of temporalis coming. Because of this tendon inserting in the posterior most part of retromolar pad area, we don't cover the denture base completely over the pad. We just cover it only till the 2/3 of the pad. Posterior 1/3 we don't do it. Why? Because as and when the movement will occur, chances of dislodgement are there. So there is a nice question that is there in a question bank. Retromolar pad area should be covered by denture base, should not be covered by denture base, has a tendon of temporalis muscle attached to it, and there is a fourth option. Now, when you select your answer, your statement should be 100% correct. Retromolar pad area should be covered by denture base, but nothing has been mentioned with clarity how much. Should not be covered by denture base is a wrong statement. But has tendon of temporalis muscle attached to it is a 100% correct statement. So I'll prefer that as my answer. And remember this over here, because the posterior 1/3 of retromolar pad area has a tendon of temporalis, that is why we don't cover it completely with your denture bases. Now, apart from that, see, this is the coronoid process. If any of you just wants to revise it, yes, let us just have a look at what else. Relieving structures. So first is mental foramen. Mental nerves and vessels exit out of it. So mental foramen is a relieving structure. Second one which will be present is genioglossus and geniohyoid attachment onto the genial tubercles. So genial tubercles present on the lingual side Again, a relieving structure, something that you have to relieve. Even the mylohyoid ridge also has to be relieved, is a relieving structure because it is a sharp ridge prominence. Just a second, let me have a look at our chat. Okay, so Prashant, your question is not very clear. Many contraindications related to boundaries of buccal shelf. There are no contraindications. The boundaries are very clear, and that is your buccal frenum and your retromolar pad area, external oblique ridge, and your crest of the ridge. That is going to be there. I just have an instruction from our backend team that will give you a break at this point. So, grossly, if I just revise it for you, we have covered retention stability support, we have covered maxillary anatomical landmarks, we have covered all of the buccal structures, your buccal shelf area, point related to distobuccal sulcus, then your frenums and vestibules I have covered. Lingual part of mandibular anatomy is left, which I'll start for our students on our application. After this particular link ends and the video ends on public streaming on YouTube, we'll start on our DBMCI live application. There, I think the backend team will post you a link for it. I'll give you a break for 15 minutes. 7:15, we will start with lingual anatomical structures of mandible, and then we'll proceed on to our impressions and jaw relations. And for all our students that have joined on YouTube, I wish all the very best for you. If you want to join for further classes, you can connect with our team. We'll put the break onto this particular session. For all our DBMCI students, you will get a fresh link for the application where we can join again, right? So we put an end to this session, and I wish all the very best for